Hello, Nursing 303 students. This is Carol Kruger, your instructor this term, and this presentation is for week 2 of your class. We have been studying chapter 65 in your basic nursing book, and so we have gotten as far as page 1025. So this week, we will be finishing this chapter. It will be in a series of videos. It came out to be too large of a file for me to try uploading at one time. This week, you have your homework due today, and I see almost all of you have finished your homework, and that is on My IoT, chapter 65. Looks like you've done very well on that. If you have any questions about that, please feel free to email me. I will also put that up for review after everyone has finished and leave it up for review for at least a day. I will also be sending out emails to keep you up with anything going on with this class. After you do the review of chapter 65 and I record the grades, I will be putting up your next homework assignment. You can look at your schedule to see when that is due, and that will be chapter 66. Hopefully all of you have all of the schedule for this term, all of the PowerPoints, all of the homework, and all of the study guides. If you do not, then please contact me because I have extra copies of this at the school that I could meet you there and give it to you. You will have a quiz over chapter 65 next week, and this is also shows on your student outline. So any questions about any of this, please contact me. Oh, on your quiz, it will be, as far as I know at this point, on My IoT rather than Socrative, but I will keep you up to date on that. So going into this, page 1025, we have goals of prenatal care. The goals are to have a healthy baby, to have a healthy mother, not have any complications, and pretty much that's it. Components of the prenatal care, coming in early and having regular prenatal care, maintenance of maternal health. Basically, we're treating this holistically. So this isn't just the physical health, but we're also talking about mental and other problems that the mother might have. Initial prenatal visit. So I'm going to talk about this one a little bit. For the initial prenatal visit, it is best to have the first visit before the end of the first trimester. So before the end of week 13 for the mother to go in. The usual timing for these visits is going to be once every 4 weeks for the first 28 weeks, then every 2 weeks until 36 weeks, and then weekly until the birth of the baby. So once every 4 weeks for the first 28 weeks, then every 2 weeks until 36 weeks, and then weekly. Postpartum is usually something like 4 to 6 weeks after birth. In some cases, the provider may want to see the woman earlier than that. So, health history. This would be on the initial prenatal visit. This is just like past illnesses or any diseases inheritable that the baby might get, such as things like Tay-Sachs or sickle cell anemia. Are there any serious infections that the mother has had? What about substance abuse, domestic abuse, things like that? Physical examination is also going to include a pelvic exam. And during this, pelvic measurements will be made. She will also get a pap test, and there will be tests made for any infections that she may have, such as gonorrhea or chlamydia. Lab tests are going to be the basic blood type, RH factor. If the mother is RH negative, she will receive RhoGAM at the 28th week of gestation, or if there are problems before that, such as an invasive procedure, such as an amniocentesis, where there could be a problem of the blood mixing. Other blood tests that the mother would get or may get would be a syphilis test, CBC, a rubella titer. We talked about this a little bit, rubella. Another word for that is German measles. It is a virus, and it can cause birth defects in the fetus, or it can even cause the death of the fetus. So if the mother comes in contact and actually develops the German measles or rubella, there's an 85% chance that the fetus will be affected by this. She cannot get a vaccination during the pregnancy. Women would have to wait for 4 weeks after getting an immunization to get pregnant. So HIV testing, every woman should be offered this. They can decline this. There is nothing to force them to have this, but if they were HIV positive, it would be very, very beneficial for them to start getting medication that would help them, but also keep the fetus from contacting HIV. Urine testing, every time mother goes in, she will get urine testing. And this would be for at least albumin, glucose, and bacteria. This would be a clean catch. They can also do urine testing for a urine pregnancy test. TB testing, every new pregnant mother should be given a TB test. Also, there would be genetic background. So going over these things that might affect the fetus. In determining the baby's due date, one thing to remember is full term is 280 days. So that is 40 weeks exactly. This is determined, going this way, from the first day of their last normal period. We can also say that this would be 266 days after fertilization, or 38 weeks exactly since fertilization. The estimated date of delivery can also be determined from an ultrasound if it is not known when the woman had her last normal period. Risk assessments continued, page 1026. So after the first initial visit, I was telling you how often she needs to go back in. One of the things that would be taking place during these other visits is the uterus is measured every time for its height and its circumference. There's also the weight of the mother that is taken on every visit. Fetal heart tones, which would be hopefully between approximately 120 and 160. They can do an ultrasound at 16 to 20 weeks, and that will show the gestational age of the baby. They are also testing or looking at the mother for edema. it is sometimes women will have it in the feet or the very lower extremities. So basically seeing if it is progressing, how much edema, and is it going up into the upper body or even into the face or around the eyes, which would be a bad sign that we will talk about later. One of the other things, additional tests, is the maternal serum alpha fetoprotein, which is a blood test that is given to the mother. So it's also called an MSAFP, maternal serum alpha fetoprotein. And it is usually done between week 15 and 19. And it is screening for neural tube defects. The neural tube is what is going to be the brain and the spinal cord. They can also screen for other problems. This also screens, as for an example, for Down syndrome. And this would be called a triple marker screen. High alpha fetoprotein signal a neural tube defect. And they can do other things to verify this, such as an amniocentesis or an ultrasound. Some of the other things that they might do would be diabetes screening between 24 to 28 weeks. And this could be a 1 hour random glucose tolerance, where they drink 50 grams of glucose. They wait for an hour and are tested. So if they have elevated levels, that may mean that they have gestational diabetes. They also, for the Rh antibody test, they repeat this at 26 to 27 weeks. And if they are negative, they would give RhoGAM at 28 weeks if the antibody test is negative. They sometimes will also do other STD screening depending on the situation at about 36 weeks. Here's a picture of some neural tube defects, and we can see how some of these affect the brain and some of these affect the spinal cord. So the one at the top that is labeled anencephaly, so this just means open brain and lack of skull vault. So the brain is either absent or very, very small. We also see down at the bottom that spina bifida can be hardly noticeable up to at the end on the right of having myelomeningeal. Okay, I got it out, which is an open spinal cord with a cyst on it. So these are just pictures of neural tube defects that can be perhaps diagnosed early with the MSAFP. So we have a question here. A woman's due date is based on her first day of the last menstrual period. True or false? True. We do make sure that it is the last normal menstrual period. And if that, like they say, cannot be recalled, then they can do the previous one and go with that. I would like you to look up Nagel's rule, and this will give you a way of determining the due date. So if we do go by the first day of the last normal menstrual period, and we add 7 days, and we subtract 3 months, we should come up with a fairly accurate due date. Health promotion. Health promotion. I'm going to be going through some of this. You need to read this in your book. You can see there's a couple of things that are in red, which usually means they're important. So We already know that the woman is having decreased peristalsis. Everything is going through her intestines, through her gut, much slower. Get every little bit that the fetus needs. So she will need fruits, vegetables, moderate exercise, fiber to help her get through that. Oil and sweat glands are more active. So they suggest a daily warm bath or shower and shampooing the hair. The last few weeks, they recommend to not take a tub bath. The reason for this is because of falls, not because of infection. The woman during the last few weeks is more likely to fall and perhaps injure herself and or the fetus. For oral hygiene, we mentioned this word before, Taoism. It's spelled P-T-Y-A-L-I-S-M, and it means an increase in salivation. It is annoying, but it does not cause cavities. It does not cause oral problems, other than just having more saliva. They also suggest that the mother does not douche, and if she has questions about this, she could talk to her medical provider. For breast care, supportive bra, number one, which may need to be a larger size. Use little or no soap on the nipples if the mother is planning on breastfeeding. Do not use lanolin. Do not use other ointments. Do not stimulate the nipples in the third trimester, or this could start contractions. Under rest, may need more rest than usual, but you can carry on the normal household duties. Sleep. How can you get comfortable when you're pregnant? They suggest sleeping on your side, either side. Left side is usually better, but whichever side is more comfortable. Do not sleep on your back. This is something that you would definitely educate the woman about. Why is it that she should not sleep on her back? And they're talking about having supine hypotension syndrome. So supine meaning lying on the back, hypotension, low blood pressure, syndrome meaning what is going to happen there. Some different things happen. One of the things is you have the weight of the amniotic fluid, the weight of the fetus, putting pressure on the blood vessels. And we're talking about the large vein, the vena cava. We're also talking about the arteries or the aorta. So we don't want the fetus on the major blood vessels. It can interfere with the vena cava and the aorta. Blood can be trapped in the lower extremities. So we're talking about not having good circulation to the fetus. Exercise and posture. Swimming pool is good. Swimming, that's always good. Swimming in a lake is not good. Walking is good. It should be a daily exercise, not something sporadic. We would teach the mother not to get overtired, not to get fatigued. And there's some guidelines for this, and it is not to have the heart rate over about 140 and limit strenuous exercise to 15 to 20 minutes. Avoid extreme heat, avoid high humidity, avoid air pollution, and high altitudes. High altitudes would be what? Having less oxygen, and thinking particularly of the fetus in that case. Exercise danger signs. So these are some things that the mother should know that she would need to report. Stop the exercise, report these. If she has pain, if she has uterine contractions at intervals of 15 minutes or less, if she has vaginal bleeding, if she has amniotic fluid leaking, if she becomes short of breath or has palpitations, if she has tachycardia, nausea and vomiting, visual disturbances. And remember about visual disturbances, this will never be normal. This will always be something to investigate, thinking particularly of high blood pressure. Decreased fetal movement would also be an exercise danger sign. When we talk about activity also, the mother is going to need more calories per day. And your book talks about this. It's kind of confusing because it gives you one number on one page, and then as you go through. So we're looking at how many extra calories. And usually it's between 200 and 300 a day, or somewhere right in that vicinity. So look at that so that you know what you could tell your patient. When we get into sexual relations, it says sex is usually safe. This doesn't mean that you just need to be hugging. So it is safe if it is comfortable and if there are no high risk factors present. We talked about placenta previa, meaning that the placenta is partially covering the cervix or right on the edge of it. In that case, they would have to talk to their provider. If the mother was in preterm labor, it would not be safe to have sex. If her membranes are ruptured, it would not be safe to have sex. Risk due to penetration. If there is any bleeding, do not have intercourse until the problem is diagnosed. It may be something that is very serious or not. So it needs to be diagnosed if there's any bleeding. If the partner has an STD or some kind of infection, or if the membranes have ruptured, no intercourse. For some people, there can be initiation of preterm labor by being aroused. So something else to think about. The same thing, orgasm may cause preterm labor and contractions. I'm going to stop here for this presentation and continue this later today. So I will label these as presentation 1. And we will get through this a little bit at a time. Once again, if you have any questions, be sure to email me, and we'll kind of do this day by day as this situation progresses. So thank you for being here, and I will be emailing you, but I will also be putting up another presentation. So thank you for being here. Bye-bye.